Hello, everyone, and welcome to our panel discussion on global perspectives on endometriosis. My name is Vimee Bindra, and I am the manager of the care program at SRC, and will be moderating our discussion today. Before we get started, just a couple things to go over. There is a Q&A tab where you can submit questions throughout the webinar. We have blocked off some time at the end to answer these, and there are also a couple polls that will pop up for you to answer throughout the webinar. The first of these will be opening now, so if you could just take some time to let us know where you're joining from. We will then introduce our panelists and get into our discussion, which is broken out into a few categories just to keep us on topic. So first of all, a brief overview of SRC. We are a nonprofit patient safety organization that accredits the top facilities and medical professionals worldwide who excel in patient care and are committed to providing high-quality outcomes and promoting a culture of excellence. SRC has accreditation programs in almost 30 specialties, including endometriosis care and minimally invasive gynecology. And all of our panelists today are SRC-accredited providers. So then to introduce each of our panelists today, we'll start with Dr. Vimee Bindra. She is joining us from India and is a master surgeon in multidisciplinary endometriosis care. She's the founder of the Endometriosis Foundation of India and specializes in excision surgeries for endometriosis and fertility-enhancing minimally invasive surgeries. Dr. Bindra is an advocate for education and awareness for endometriosis. We also have Dr. Randy Lizardo joining from the United States. Dr. Lizardo is in private practice with Capital Women's Care in Maryland. He was first accredited as a master surgeon in minimally invasive gynecology in 2020, and he specializes in the minimally invasive treatment options for fibroids and endometriosis. Then we have Dr. Shiva Harikrishnan joining from the UAE. Dr. Shiva is dually accredited as a master surgeon in endometriosis care and minimally invasive gynecology. She has more than 30 years of gynecological experience and has taken a special interest in minimally invasive procedures throughout her career. And then rounding out our panel, we have Dr. Charles Nagy, who is also from the United Arab Emirates. He was the first SRC master surgeon in endometriosis care, and like Dr. Shiva, is dually accredited in minimally invasive gynecology. He is the head of a multidisciplinary endometriosis center and specializes in the advanced excision of deep infiltrating endometriosis. So to kick all of this off, as SRC accredited providers, that does have an impact and play a role in your approach to patient care. So if you could just each kind of describe what that is like and kind of how you incorporate that into your dealings with patients. We'll start with you, Dr. Lizardo.
So I think SRC has really helped patients feel comfortable in myself as a surgeon. One thing that's great about the SRC is that it's a voluntary organization that's not affiliated with any particular hospital system or medical system. So it's an unbiased organization that vets not just providers, but the health systems that they're involved with and in. And I think for patients, it helps them navigate it's a little bit of a maze trying to find out which certain surgeon or provider would be able to provide a certain level of care. We all graduate from great medical institutions. We all have significant training in terms of our individual fields. But I think for patients, having the SRC designation helps them feel comfortable with the individuals who would be providing at least surgical care. And also it helps institutions and medical health systems find and identify providers who also fulfill a certain level of expectations. It's not based on a popularity contest. We're not simply just paying to have an extra badge on our websites or our white coats. The process is actually pretty extensive. And as someone who's been through the process of renewal a couple of times now, I can see why it can provide patients with a level of comfort with who's taking care of them.
And Dr. Shiva, do you have anything to add?
Yeah, SRC accreditation has really instilled a sense of trust and confidence in the patients approaching us for surgical care. And really also the referral doctors also very happy to see that you are a master surgeon in minimal invasive gynecology and multidisciplinary endometriosis care. So they have a place to refer for tertiary or advanced care for deep infiltrating endometriosis. And well, about the what I feel after getting this SRC accreditation is not just a two badge on my white coat, but it really has made me more responsible, and I have gone into more details of how I can improve my surgical skills and how I can improve my surgical techniques, how I can get like a ground knowledge about the pelvic anatomy, the predictive anatomy. So more and more deep into the endometriosis and minimal invasive surgery, I want to go, so that I am responsible. Just the badge of master surgeon, I should give a best care for my patients.
And Dr. Bindra.
Thank you, Jenny. And first of all, I would like to thank SRC for bringing all of us together for this discussion, which was really needed, and especially in this Endometriosis Awareness Month. And SRC accreditation sets us apart from other providers, and it also communicates crucial information, how our unique approach or how we treat our patients, how we maintain our standards and highest quality of care for our patients. Now, endometriosis is treated by everyone, but everyone is not doing a multidisciplinary approach. Most of these patients find difficult to find experts. So if you are SRC accredited or you have gone through this process, the doctor who has gone through this process only understand what it means. And for every patient, we maintain the standards and quality, and we try to give our best so that our patients has good clinical outcomes, less recurrences, good quality of life. So this is how it sets us apart. It also signifies excellence in patient care, our adherence to safety protocols, and more than that, our commitment and passion to treat endometriosis.
Mm-hmm. And then Dr. Nagy, if you have anything to add.
Hi, can you hear me well at least?
Yes, we can.
Yes. Well, I come from a British training background, and back then in 2010, we introduced the BSGE accredited multidisciplinary care centers. And since then, we noticed the significant improvement in patient care. But unfortunately, when I moved to Dubai, we tried to establish the center here in Dubai, but the BSGE ceased to sponsor international centers. So this is why we seek SRC sponsorship, and I was very happy to find out that they are already started a multidisciplinary care endometriosis accreditation. I also took guidance from my colleague and Professor Oras Roman. So I was very happy that we managed to get through the SRC multidisciplinary assessment that gives a more systematic and structured approach to endometriosis, which is what patient needs. And this gives actually patient trust, credibility in the center they are treated in. So thanks for the SRC, and we're very happy to continue delivering the best for our patients.
Mm-hmm. All right. So, of course, we are here today to discuss endometriosis. Our audience is likely familiar with what endometriosis is, and obviously this webinar was open to everyone from all walks of life, whether they are medical professionals treating endometriosis, patients dealing with it, or support networks that are obviously providing support and care to their friends or family members. But there is obviously more understanding needed for endometriosis. So, of course, endometriosis is a painful chronic disorder where endometrial tissue grows outside of the uterus. And this tissue continues to act as endometrial tissue normally does. It thickens, breaks down, and bleeds with each menstrual cycle. However, because it's outside of the uterus, it becomes trapped, and this can cause symptoms including pain with periods, intercourse, bowel movements, and urination, excessive bleeding, and infertility. And on the organs that the tissue attaches to, it can cause scar tissue and adhesions to form. So, Dr. Lizardo, who is at risk for endometriosis?
Essentially, anyone who's menstruating. In general, it's impacting women of reproductive age, but women who are even menopausal can actually still suffer from endometriosis symptoms, even if technically their ovaries have not been functioning at the same level as they were when they were younger. And I say people because even transgender patients actually can suffer from endometriosis. And sometimes they actually suffer in silence because a lot of times they're not seeing care providers in the traditional sense. So definitely anyone with menstruation and reproductive age could be at risk for endometriosis. Those who have a family history also tend to have a higher risk. Some studies show anywhere from 5, 7, 9%. But a lot of the times I think that data might be a little bit skewed because, as we all know, and as many of the audience members may know, sometimes endometriosis goes undiagnosed. So patients may have aunts, mothers, other family members who have suffered for years, and everyone just assumed it was normal. So my guess is that those familial links are probably a lot higher than a lot of most people are reporting.
So would you say that there is potentially a genetic component to endometriosis?
There's some studies that show that there's probably multiple genetic connections, polygenic etiology of the disease. There's no one specific endometriosis gene, I would say, that we've identified, but there's definitely a predisposition for some individuals when combined with the environmental factors, other medical comorbidities that would set the stage for endometriosis for developing and then progressing throughout that individual's life.
All right. Well, we did have one poll that we opened, and we wanted to see what our audience members thought about the diagnosis timeframe for endometriosis. Overwhelmingly, most of our audience believes it is 7 to 10 years for a patient to achieve a diagnosis with endometriosis. So, Dr. Bindra, what can you say about that?
Jamie, it's the evidence has shown that diagnostic delay of 7 to 10 years for endometriosis is there, and there are different levels of delays. Mm-hmm. And I would start that it starts from the household level or the society level, because there are many myths prevalent in the society where they say painful periods are normal. Mothers and grandparents also tell them that painful period is normal. I used to have it and it is fine. That is the first level where these patients get a delayed diagnosis. They are never taken to the doctor. The second level comes at the doctor's office also. We have patients who come to us and they tell us that their symptoms were always normalized. Doctors have told them that pain is normal. And another thing is pushing towards childbearing and marriage. This is very much prevalent. Even our colleagues practice that, and they tell them that you get married, have a child, your symptoms will go away and your endometriosis will go away. So pregnancy does not cure endometriosis. So these are the main issues where the diagnosis gets delayed, and the patient, when they come to the experts, it is already advanced disease. Then comes the role of imaging. We have lack of experts for imaging and for excision both. So most of these patients, they go to the doctor, their ultrasound report or MRI report invariably comes normal, and again they are dismissed. There is another level of delay, and that's a very crucial delay until unless we suspect that the patient has endometriosis. Even if imaging is normal, lack of experts are there, I understand. But as an endometriosis expert, we have to suspect based on her history and clinical examination. And if imaging is negative, we can always offer a laparoscopy. Now, with good imaging and good expert training, we can pick up almost all lesions of endometriosis with advanced ultrasound and MRI. So experts who are treating endometriosis, they should also learn how to do the imaging and read the DICOM files for MRI. Then these are the levels where the delay happens. And also there is a reluctance to do laparoscopy if all imaging is negative. Because it is an invasive test, and nowadays it is not a test, it should be a therapeutic intervention. Once I go in, I should treat it. So these are the levels where multiple levels are there where delay is happening, and patient ends up getting a diagnosis after 7 to 10 years, after visiting at least 7 to 10 different specialists, being dismissed, gaslighted, and then they receive a diagnosis. By that time, a woman who is trying for pregnancy, her ovarian reserve has reduced. There may be an organ damage, which was not there 10 years back. So we need to work upon this. We need to revise these, and we need to correct these things at every level. School education, society education, community education, everything needs to be revamped. It's not only doctors who can help them, it's also the society, families need to be educated for this.
Mm-hmm. So touching on the imaging component of diagnosis, does this imaging primarily focus on the pelvic region, or is it standard, or do you think it should be standard to look at other areas?
Imaging is directed by patient symptoms. Mm-hmm. What the patient says, we have to respect that, and we have to look at the pain pointers. If the patient's primarily, we all know pelvic endometriosis is the most common. So we first is compartment-wise imaging is important, following the IDEA protocol and mapping of endometriotic lesions as per the latest #NCN, which we follow in our practice. So first is complete pelvic evaluation, anterior compartment, middle and posterior compartment, follow the IDEA protocol so that we don't miss any of the lesions. And then the extra pelvic locations, if we talk about diaphragm, lungs, they come later definitely because the incidence is less. But if the symptoms are pointing towards that, I will be more aggressive on looking at those areas as well. But in pelvic, we look at the bowels, ureters, bladder, and all the adjacent structures, the parametrium, nerves regularly for every patient.
So a question that I will pose to all of you: what challenges do you see patients encounter in your specific geographic areas? Dr. Nagy, if you could start us off.
Yes, I would summarize this into a few points. Number one, awareness. Awareness amongst patients and junior doctors and GPs. To this moment, we have so many patients who come with typical symptoms of endometriosis, and they don't know what is the disease. And they've been under their care, the care of their doctors for years. The latest example of a woman with a huge, massive cesarean section scar, and she's bleeding for quite a few months from the scar itself. That the scar goes back to 5 years, antecedent cesarean section. And the minute you look at it, and it's a spot diagnosis of scar endometriosis. But we lack the awareness. She was not guided by her doctor. Eventually, she came to us knowing that this hospital offers endometriosis care. So awareness between patients and the doctors alike. The MDT approach, the introduction of multidisciplinary care approach was not existing actually before we introduced the service. We challenged this in private sector because why you need a colorectal surgeon, urologist, and gastro dietitian sometimes, fertility specialist, pain management. Why do you need all that to establish endometriosis cells? So this is another challenge. One of the biggest challenges is funding. Here, patients are funded by insurance. And we have many patients who knew about the diagnosis, but they can't come to have their surgery because insurance doesn't cover, or they don't have the fund for this very expensive surgery. Over the past 4 years, we also encountered the problem of the population dynamics in Dubai, that patients keep changing jobs, changing insurance provider, and changing even location. So they miss out the regular follow-up for the disease, whether they are on medical surveillance or post-surgery. One last thing we noticed also, the conflict of interest between different private sector providers. Some non-accredited doctors, they try to approach from their gynecology only point of view. And of course, the patient will end up in having several surgeries before having the definitive surgery. Also, the conflict, which we will talk about, the IVF providers, who some of them dismiss completely the idea of endometriosis because the treatment is just IVF. And we have rounds actually of discussion and rounds between us. So in my view, these are the challenges that we face here in this region, in this area. But we tackled all, and we continue to tackle them.
And Dr. Shiva, I know you're in the same area. Do you have anything to add or expand on there?
Yeah, already Dr. Nagy has pointed out all the challenges what we are facing. Yeah, these are the challenges actually we are facing, and sometimes cultural problems also, because the patients find it difficult to come out with the problem of dyspareunia or dysmenorrhea, and even for the adolescent people, they think that it is normal, and it's quite personal thing to come and address it to the healthcare provider. They have some restrictions I have noticed in my practice. But these things are we are trying to get over by educating them and using questionnaires while the patient comes for any pelvic pain or lower abdominal pain, so that we can pick up most of the cases. And the insurance is a big time issue, because those patients who knows that we are experts and we are the center of excellence, but they are not able to reach the experts, and they are still with the GPs, and clinic practice is very prevalent here, and so they end up going to clinics, and then the doctors will, the GPs and the other general gynecologists who is not having that much awareness about the endometriosis, they just keep them and not evaluating them, not having the understanding that it is the features of endometriosis, and still they keep with them, and for more medical wandering we can see here. And finally, when they reach the experts, it takes like ages, like 7-8 years.
And then Dr. Lizardo.
I agree with everything the other panelists have been saying. And it's a little bit unique right now, because I practice in Maryland, but I'm currently in Florida. And maybe it's a random coincidence, but aside from the social normalization of symptoms, aside from individual physicians and providers who want to be able to take care of their patients and not refer them out for whatever reason, and aside from the pressures of the insurance companies, it seems like now there's almost like political aspects affiliated with endometriosis care. There's actually legislation, and it's, again, ironic that this is Endometriosis Awareness Month, but legislation that's potentially being passed that's banning females from talking about menstrual symptoms or menstrual periods in schools. So that's infiltrating even at the political level in elementary schools. So I'm curious, number one, if those things are going to pan out, but I'm also concerned with the potential downstream effects what will happen, potentially in the future.
So y'all all have touched on the importance of multidisciplinary care for endometriosis, but what would you say are the provider-to-provider challenges that you encounter when diagnosing a patient or when a patient comes to you? Are they more referral-based, or is it awareness and education of endometriosis that you encounter with those provider interactions? Dr. Bindra, what can you say on that point?
So when these patients come to us and they have got multiple opinions, so they start asking us as well. See, there are two sets of patients. One is patient who has done their own research and they understand endometriosis. They come to excision expert. It's a win-win situation for both of us. It is very easy to counsel them. But there is a set of patients who do not understand endometriosis and they have gone to multiple colleagues of us and they have seen them and they have got different opinions. Somebody tells them this is normal, it's fine, you just live with it. Somebody gives them a hormonal medication and tell them to continue like that. Somebody gives them a surgical option, but say you can try even after childbearing or you can wait. Like they are in a dilemma sometimes. Then it becomes very difficult for us to convince them that this is a progressive disease, silent organ damage can happen with this disease. So referrals, when the patient comes on their own searching for an excision expert, those patients, they understand what an excision surgery means and what kind of care they are looking for. But then the patients who do not understand endometriosis much, it becomes, at least in my country, this set of patients, it's become difficult for me to, it is challenging for me to tell them that excision surgery helps, multidisciplinary team helps in endometriosis. They say, I have ovarian cyst, why you want to operate on my bowels? So these are the challenges we face when our colleagues tell them something else. And it becomes for me as a MDT practitioner to tell them that it is a multidisciplinary approach and we need to treat the disease all at once and not in multiple settings. So this is to avoid multiple surgeries. This is to avoid recurrence, give them the good quality of life. So when the provider, when the patient comes from another consultant to us, or when the patient does not have enough background knowledge of endometriosis, it becomes difficult for us because some of them are promoting hormonal treatment for years together.
Mm-hmm. All right, and then we will turn our conversation to treatment of endometriosis. Dr. Shiva, what are the surgical and non-surgical options for endometriosis treatment?
Yeah, well, the medical treatment includes a lot of options ranging from non-steroidal anti-inflammatory drugs and then giving progestogens like oral contraceptives and the specific drug for endometriosis like Dynogest and Depo-Provera shots. And finally, to make a menopause stage with GnRH injections, which can be given monthly or in 3-monthly intervals. And coming to the surgical and definitely other herbal medications, B6, vitamins, a lot of other medications are also there, but not having a lot of evidence to support that. Coming to the surgical management, basically for the endometrioma, the minimal invasive surgery is the best line of management, and the excision of the endometrioma. And coming to the rectal or the bowel endometriosis, depending upon we have to have a very good imaging technique, and we should be able to accurately diagnose the nature and the location of the endometriosis, deep infiltrating endometriosis, so that we will be able to give a precise excision of the deep infiltrating endometriosis. In case of bowel endometriosis, depending upon the the findings, which we request our radiologists, and we are also trying to get more expertise in the making our own ultrasound dynamic pelvic scan imaging and interpretation and MRI interpretation to localize and to see the size of the endometriosis, the depth of invasion into the lumen, where it is, how much is invaded into the bowel lumen, in the bowel wall, whether it is more than 50% or less than 50%, the location, like it is multicentric or multifocal. All these things are important to precisely decide the mode of treatment. If the lesion is a small lesion, like less than 1 centimeter, we usually do rectal shaving. And in our practice, we usually shave from the shaving is in the rectal side. Some centers, they do from the side of the uterus. But we try to do and shave from the rectal aspect of the recto-vaginal endometriosis or recto-sigmoid endometriosis. Then if it is between 1 and 3 centimeter, then we go in favor of discoid resection. And we are more in favor of discoid resection than in going for end-to-end, the segmental resection and end-to-end anastomosis. The only indication for the end-to-end anastomosis, the segmental resection and end-to-end anastomosis is like multicentric disease, and if the lesion is very big and multiple lesions are there, and if it is invaded more than 50% of the bowel wall, then we go for the segmental resection and end-to-end anastomosis. We try to do more of discoid resection in our practice. And the one thing what we have to be careful with the involvement of multidisciplinary team and the colorectal surgeon, we are able to do very good the surgical experience for our patients. And basically, we will be very careful not to include the posterior wall of the bowel when we do the discoid resection. Yeah.
And I know, Dr. Bindra, you have specialized in bowel endometriosis in your patient care. So what can you tell us about your approach for that treatment? Oh, I believe you're still muted.
Yeah, I'm sorry. So Shiva was saying that bowel involvement. So we also do a preoperative mapping. First of all, we know where the lesions are. What is the distance of lesion from the anal verge? That is also important. And if I look at our bowel endometriosis treatment, our bowel shaving is 77.1%. Rest is discoid excision and 2 to 3% is segmental resection. We do bowel shaving for lesions even more than 5 centimeter, because that criteria of less than 3 centimeter or 3 centimeter, we had a big discussion with Dr. David Redvine also, because initially there was no criteria and there was a discussion with the colorectal surgeons. So he put a criteria that less than 3 centimeter nodular, more than 3 centimeter nodal segmental resection is needed. But the evidence from Olivier Dones and others has also shown that shaving is also a complete treatment, provided it is done completely and it does not involve the mucosa. So we do shaving for much bigger lesions. We do discoid also for bigger lesions. With robotic advantage, we can shave off the lesion completely, and we can also do the disc excision for little bigger nodules. Yes, segmental resection has its own indications when the nodule is involving more than 50 to 60% of the circumference, multifocal lesions are there. Definitely, we also do segmental resection, but then we have a radical but conservative organ preserving approach. And our recurrence rates are standard, like around 8 to 10% in our patients also. So it does not mean that all patients need resection. Resection also has its own side effects, long-term morbidity. So we have to be very judicious when we take these radical approaches for our patients. Real indications, definitely we go for segmental resection. But then shaving is also complete excision. Some people believe that shaving is not complete excision. Shaving is just partially removing the nodule. It is not like that. Shaving is also complete excision. So it all depends on the patient's symptoms, location of the disease, multifocality of the lesions, and the expertise available.
Mm-hmm. All right, so we know about the link between endometriosis and infertility. So Dr. Nagy, what are the options that exist for patients with endometriosis who wish to become pregnant?
Right. Well, this is one of my favorite subjects because it's a matter of debate always between us and the IVF specialists. I find the difficulty is that both conditions are very mysterious. We have 30 to 50% give and take between infertility and endometriosis. Nearly 50% of endometriosis patients, they have some difficulty conceiving, and a large percentage, 30 to 50% also of infertile patients do have endometriosis undiagnosed. Prolonged infertility makes endometriosis worse, and this is one of the risk factors for endometriosis. The difficulty here is that unifying the terminology for endometriosis. We're talking about endometriosis as an umbrella. There are several diseases under this umbrella. So if you want to talk about endometriosis and infertility, you have to divide it into ovarian, deep endometriosis, superficial endometriosis, and other types, even distant site endometriosis, in order to understand the impact of each and every type of these lesions. So overall, for infertility, the couple will have to go through rigorous infertility investigations. In general, ovulatory tubal obstruction, semen abnormalities constitute 75% of infertile couples, and roughly 25% of the remaining are just unexplained. Of this group, unexplained, we have 40 to 50% due to endometriosis. The impact of endometriosis on fertility is very complex. It's rather than the simplistic view of just blocking the tubes. It starts from the ovary with impaired folliculogenesis, fewer follicles, to the ovulation process itself, fewer oocytes and altered oocyte quality, moving on to fertilization, poor sperm binding, oocyte linked, reduced fertilization rate, and then the embryo itself, poor quality embryo. And this also explains the number of failure of IVF when we go as a first line. Implantation itself is affected because there is reduced uterine receptivity and altered hormone regulation. Even centrally at the level of the pituitary, there is altered pituitary ovarian axis. The story doesn't end here, because if we talk about fertility in terms of take baby home, the pregnancy itself is affected. There is increased risk of miscarriage, preterm loss, recurrent miscarriage, and so on. So here it comes the importance of typing of endometriosis. Move on to the classification. There is no classification that fulfills the criteria of the impact on fertility. Starting from the revised American Fertility Society, or even the deep infiltrating enzyme classification, the only one that gives us a bit of clue about the impact is the fertility index. Talking about what are the risk factors associated with increased infertility in endometriosis patients. Number one is age, more than 32, superficial endometriosis phenotypes, previous surgery for endometriosis, and previous pregnancy. Previous pregnancy and duration of infertility is a good indicator of the surgical treatment. Surprisingly, ovarian endometriomas on its own is not one of the serious risk factors here. So if we talk about ovarian endometriomas in general, there are certain factors that increase the negative impact of OMA surgery. patient age, which again reflects the poor ovarian reserve, the size of the endometrioma, the bilaterality, the experience of the surgeon, the technique used, whether it is excision or ablation or whatever. And of course, the recurrent surgery. The more surgery you do on the ovary, the more trauma to the ovarian reserve. So when we manage endometriosis-related infertility, we need a proper mapping of the endometriosis, proper typing and diagnosis before we actually approach. In many of our patients who have solitary small endometrioma, not very much symptomatic, we can actually refer them for IVF to start with and see. So there are first. Clinical symptoms, you cannot give the patient the choice. Are you symptomatic or you want to have a baby? You have to put the patient quality of life and symptoms first. The investigations indicating the endometriosis type. And those patients who are not diagnosed through ultrasound scan or MRI, then you do not hesitate to do laparoscopic evaluation and treatment. So this is how we approach it. We believe that not only treating mild endometriosis does have a positive impact on fertility, but also treating deep infiltrating endometriosis has a very positive impact on fertility. And in our published series, we have pregnancy rate of 65%, which is comparable to most of the published research as well. 50% normal pregnancy and 50% pregnancy after IVF. So we don't have conflict with IVF specialists. We do refer patients sometimes for egg freezing if they're not contemplating pregnancy soon, before contemplating surgery that might compromise their recovery for months if it involves bowel surgery. So we have very open-minded approach when it comes to managing infertility with endometriosis. It's a very big subject, but this is how we manage here, and this is our philosophy.
Dr. Lizardo, are there comorbidities or correlations with other gynecologic conditions and endometriosis?
Definitely in my practice, and I guess published data, like I say almost all my patients are being for one condition, whether it's fibroids or adenomyosis or abnormal bleeding. When it comes time for the laparoscopy, about 50% of those patients are going to have probably endometriosis, some stage or level of disease. A lot of these symptoms are similar to those conditions as well. And I guess the different etiologies and histories of patients could also impact the presence of endometriosis. For example, one of the theories of the potential spread or development of endometriosis is a prior history or surgery that the endometrial cavity was actually breached, whether it's a myomectomy in the past or a cesarean section in the past. Sometimes those cells can actually implant in other areas of the pelvis. So it's always interesting whenever I go in during surgery and I see other operative reports make no mention of endometriosis, whether it's a C-section or a myomectomy, and then I'll see them however many years later, and there's actually a significant level of disease for certain patients. What's challenging is when patients are treated for one of the former conditions, I mean fibroids in particular, many times the disease is present, and I look at reports, but when you have surgeons that aren't necessarily as comfortable treating the disease, depending on where it's located, a lot of times it's actually left in place. And they assume that if the patient isn't having significant pain symptoms, that there wouldn't be a need to potentially address it. And unfortunately, that leads to progression of the disease. So when treatment eventually down the line takes place, it can make the procedures a little bit more exciting. And then that can also potentially impact, or most likely impact, the recovery and outcomes of those patients as well. So definitely there's a lot of comorbidities in terms of other conditions.
And so when you all are working with your multidisciplinary teams, what is the makeup of these teams?
I think
Yeah.
from my perspective, my practice, we've mentioned other surgeons, colorectal surgeons, and fertility specialists. I think tackling endometriosis needs to start at the initial consultation, because a lot of these patients have suffered for years, if not decades. Aside from the surgical aspect of treatment of the disease, there's definitely the psychological aspect and the impact that it's had dealing with years of suffering, pain, and sometimes people even say neglect. And I think pelvic floor physical therapy is a huge component of addressing the short and long-term impact of endometriosis, because those implants sit on top of muscles. Those muscles are connected to nerves, and just excising the lesions themselves, while necessary as part of the treatment process, I think patients need to realize that excision in and of itself may not completely resolve and relieve all their symptoms. So even after the surgery is completed, there could be weeks, months of continued treatment that involves some of these other specialists, whether it's therapists, pelvic floor physical therapists, sometimes pain management specialists. So it goes well beyond the surgical aspect of that. And I think setting patients' understandings and expectations at their initial consultation, number one, it helps validate the fact that they've been dealing with things for so long, but at the same time, it helps set their expectations for how we can best manage things.
All right. So then, of course, the big question, where do we go from here, and how does treatment for endometriosis progress? So we have discussed during this panel the importance of education and awareness of endometriosis. So Dr. Nagy, what do you currently do to educate your patients and even other physicians about endometriosis and what they can expect?
Right. Well, in terms of our patients, before we embark on the project of endometriosis multidisciplinary care, we devised a patient leaflet detailing all the possible symptoms that the patient might have, and also the impact of endometriosis on different aspects of the woman's life, physically, socially, psychologically, even energy levels. Some patients complain of fatigue, unexplained fatigue. I had one of the patients giving feedback that for the first time now after surgery, I feel good. In my view, what patients need from us as the best method of education is to listen to them. Most patients just need to listen, the doctor to listen to them and follow the lead they are telling you. So if the patient is saying, I have pain here, although there is nothing physically here, you have to follow that lead. We learned a lot from our patients.
Mm-hmm.
I have pain here every time I have a period, and it turns out she has a 10 centimeter diaphragmatic and liver mass due to endometriosis. So we explain to patients. I give my patients time, nearly 45 minutes per consultation, to explain the disease, all the impact of the different types of the disease on all aspects. I also give them leaflets, give them my time and attention. If we move on to physicians, physicians also need education about the disease and the impact on different aspects, and listening to their views and educating them of the different types of endometriosis and the fact that it's a disease of multiple illnesses. And if your patient needs an outside consultation, this doesn't mean that you're losing your patients. It's a whole team looking after. You refer your patient to a urologist for proper assessment, to gastro for a colonoscopy, for colorectal surgeon to assess the impact. I must admit that since we are declared as a multidisciplinary care team, and myself as an endometriosis surgeon, we had a lot of credibility from our referring doctors that we do it this way, we do it structured, we do it right, so they trust our opinion. And some patients just come for the opinion and they go to their own doctors. We have regular seminars, and recently we have a symposium about endometriosis, celebrating our hospital's accreditation. And we had more than 500 doctors attendees. And we were very happy to share our accreditation amongst a huge number of doctors.
Yeah. So looking at research and current trends in treatment, where do you see endometriosis treatment going in 10 years? Dr. Shiva?
The research, actually, it is underfunded. The lack of research funding, especially for a very important women's problem, which is affecting 10% of women, affecting the psychological, social, and physical health of and mental health of women. Still, there is a lack of research funding is particularly striking. And for a disease like diabetes, where the annual funding is in many developed countries is around like 1,050 million pounds, whereas for endometriosis it's very worrying. It's around 25 million pounds only. It's really very particularly striking. But the research is mainly on the pathogenesis and currently interfacing with the 4 areas of research like genetics, immunology, immunology and environmental effects, and mainly one of the innovation or the global innovation is by because already there is a medical monitoring, and we have said that there is a delay of diagnosis from the symptoms to the diagnosis of around 8 years. To reduce this, like a team of endometriosis specialists with the help of the artificial intelligence engineers have designed a test called the salivary endo test or SIV test, where they check the micro RNA of the genome of to check in the saliva, so that it can be early detected endometriosis, and it will reduce the delay of from 8 years to few days. And if it is coming in a big way, it will be a very big breakthrough in the diagnosis of endometriosis. And another research where we are having a high expectation is about the treatment, non-hormonal treatment of endometriosis. And it is a molecule called dichloroacetate and DCA, which is used for the treating metabolic disorders in children. And it has an effect on reducing the lactate. Usually the lactate is formed in the body when there is a lack of oxygen. And in endometriosis, affected tissues have high lactate. And if this DCA is given, it will reduce the lactate and it will reduce the survival of the endometriotic tissue. It has been tested in labs, and a big discussion is going to come in the 15th Congress of Endometriosis, which will be held in Edinburgh by the Professor the Andrew Horn and the Filipina Saunders Professor, and they will be able to give more insight into this, which will be held in May 3rd to 6th in Edinburgh. So it will be a major breakthrough, and definitely if we can get these medication, which is a non-hormonal treatment, which can reduce the lactate levels in the endometriotic tissue, which will prevent the further survival of the endometriosis, it will be a big and a very big innovation in this field. And also as it runs in families, and there is a lot of genetics is involved, and there is research going on about those patients who are having endometriosis. They are having the DNA methylation in their DNA, and it is the epigenetics actually. And if we can find a solution for the reversal of this methylation, it will be a very big innovation which we can think about in the coming years.
Definitely a lot of exciting things on the horizon. So, Dr. Lizardo, in your opinion, what do we need to understand about endometriosis to achieve quicker diagnoses?
I think the online communities that are out there and organizations like the SRC, I think creating the awareness or starting the discussion will help create awareness, and that will lead to action. So I think what really needs to happen is it's multifaceted. So organizations like the SRC needs to continue the dialogue. The online communities need to continue their exposure of the illness, and re-education of providers as well. Not letting patients suffer for years and years and decades before a diagnosis is investigated further. With that said, and at least regionally in my area, DC, Maryland, Virginia, in the past couple of years, I've been seeing some slight changes in trends. Patients are taking initiatives upon themselves, seeking second and third opinions, and I'm starting to see changes in referral habits. Physicians are referring patients much younger, saying this patient possibly might have endometriosis. Would you consider possibly doing a laparoscopy? And without fail, I'm like, yes. It doesn't take more than one ER visit to do more investigating when the patient has ultrasounds that are normal, MRIs that are normal, CT scans that are normal. So I think that's multifaceted. Patient education, taking initiative on their own, physicians changing practice habits in the past, realizing that physicians don't necessarily need to be a one-stop shop in their office. The treatment options for all the conditions that are out there are vast. So it's hard to be a jack of all trades of everything. And people are realizing that it's okay to refer to someone else and not have that fear of potentially losing your patient. The fear of having patients have less confidence in them, I think, is less of a concern. Doctors are able to say, hey, you know what? I'm familiar with this, but there might be someone else out there who might be able to address this better. And I am starting to see some of those changes in the past couple of years, at least regionally where I practice, which is promising.
Definitely. And then, Dr. Bindra, how do you envision the impact of specialized endometriosis centers and providers on endometriosis care in the future?
We all know that endometriosis needs a multidisciplinary care, and we will go a long way if we keep on practicing that. Awareness about the disease is important. Awareness of our colleagues that endometriosis needs a multidisciplinary team management is also important. So raising awareness among our colleagues and cross specialties like radiologists, colorectal surgeon, urologist, cardiothoracic surgeon, we should create awareness among those specialties for the need of multidisciplinary treatment for this chronic debilitating whole body disease. So we have to look at a long-term, patient-focused, comprehensive, multidisciplinary care model in which we should have standardized protocols so that we can monitor these patients, the patient outcomes, the quality of life, fertility outcomes, and there should be a model for clinical outcome tracking as well. So if we do this and we have a similar database all across, we can have much more information and much more research so that we can come up with more options for treatment, and we can implement some new treatment models as well. We should also encourage developing widely accepted international parameters for assessing clinical and quality outcomes. So individual clinics are doing their work, but then we should come together, or the societies should come together to develop those standardized clinical and quality outcomes, which is little different at present in different models. So if we can have a uniform, internationally accepted model of care, which can be implemented worldwide, will have a great long-term sustainability.
All right. Well, we have reached the end of our main panel, and we are kind of right at time. So we might run over a little bit more. If any of our audience members have additional questions, you can submit them in the Q&A tab at the top of your screen. We do have one question that I will go ahead and pose to you. Do you have cases where the patient presents with endometriosis symptoms, however, lesions do not reveal a pathology of endometriosis?
Yes.
Yes.
Yes. I'm talking about personal experience of a recent patient that we treated. She had the preoperative ultrasound scan. Well, she first presented with severe pain in the right leg, starting from the groin going down, typically following the obturator nerve. And her symptoms are typically worse with the periods. So surprisingly, the transvaginal ultrasound scan mapping showed nothing of DIE. However, a very strange nodule near the iliac arteries. So following exploration, we did the laparoscopic surgery and we removed 7 of her lymph nodes. One looked very indurated and was pressing on the obturator nerve. The minute we removed it, 2 weeks later, the patient's pain disappeared completely. So clinically, the patient improved, but to my surprise, the histopathology didn't come confirming endometriosis, which doesn't mean that it is not, because we do know that 20% of cases of deep endometriosis involves lymph nodes. So the fact that it is not, it could be just a fibrous type of Mullerian metaplasia endometriosis, deep nodular one, but it certainly behaved like endometriosis and the patient is cured. So yes, sometimes the fibrotic lesions can press on the nerves and cause symptoms.
Mm-hmm.
Yes.
And Dr. Bindra, did you have something to add?
Yeah, like very early endometriosis, it has different variations. There can be different colors of the lesions also. So if you do those peritoneal lesion excisions, sometimes when we use these electrical sources, we may not find particularly those endometrial glands and stroma, and the pathology may be negative. But clinically, the naked eye appearance is of endometriosis only. So early endometriosis, peritoneal endometriosis, sometimes when the lesions are not deep, they're superficial, less than 5 millimeters, sometimes pathology may be negative for those cases as well.
Mm-hmm.
Agree.
How do you foresee that digital technologies will accelerate endometriosis care?
Can you repeat the question, Jani?
Of course. How do you foresee that digital technologies will accelerate endometriosis care?
Digital technology first is awareness. I think most of the social media handles are trying to create a lot of awareness that has created a lot of communities for patients where they are helping each other and they are getting cross referrals and they are finding the right experts. So if used in the right direction, social media and digital technology can go a long way. But we also have to stress upon that social media also has the wrong information. So we have to be very judicious what we choose when it comes to the social media and digital thing. Second use of digital technology is, as I said, the maintaining a proper standardized database all throughout the world, standard protocols and standard surgical or clinical outcomes for these patients can help us go a long way.
All right. Well, that is all the time we have today. So we will end here. Thank you, everyone, for attending. And thank you especially to our panelists for sharing your expertise and knowledge with us today.